All right. So who am I? So I'm an osteopathic physician. I am trained as a family medicine physician. I grew up in Southern Ohio and went to undergraduate at the University of Utah. I actually have a degree in modern dance. So I've always been very active in my background, always wanted to go to medical school. So I went to medical school, became an osteopathic physician instead of an MD, which would be called an allopathic physician. Did that in Southern California. Went to training in Bangor, Maine, and got my additional training in family medicine and did what's called a fellowship in osteopathic manipulative medicine. So this is what I do a lot. I take care of whole families, but then I also work on lots of people in terms of care for different types of pain and things. It's a part of me that a lot of people know about, but a lot of people don't know. So if anybody wants to come to me for that too, there's a little extra piece of what I do. My husband and I moved to Star Valley in 2010. Started down my practice in Afton. I did full scope family medicine inpatient, so seeing patients in the hospital, seeing patients outpatient in the clinic. I worked in the ER. I delivered babies. So I did it all initially, and slowly my practice has evolved and kind of backed off. We had some personnel changes. I was living in Alpine, so Star Valley Health sent me up to Alpine when that happened. And then slowly my practice has just become more and more centered in Alpine. I still do one day in Thane to keep kind of the Upper Valley folks in the loop. And so not as long a drive, but people still come to me from Alpine. Now I'm working on moving towards more of a women's health based practice, more specifically for menopause care, perimenopause care, postmenopause care. If I'm not at the office, you'll find me doing this out on a bike. You'll find me skiing. You'll find me on a fat bike in the center. Sometimes my husband can convince me to fish. I'm usually hanging out with these two or wrangling that little crazy black thing. So what are we going to do today? We're going to talk about all things perimenopause. I want us to get this conversation out there. I want everybody to tell their friends about it, and get you educated, empower you with the tools to learn more and take care of yourself as the transition starts. I want to talk about this because no one is talking about this. In the past 5 years, I don't know if you've noticed, but menopause has been having its moment, so to speak. Oprah's talking about it, so it must be a thing. I'm also getting into that middle-aged time period, so I'm experiencing a lot of the same changes that some of you are. It's a big deal to get the word out and let people in Star Valley know that there are providers who do know about perimenopause, menopause, postmenopause, because it's actually been a part of our training that's been pretty poor in medical school. You've probably heard things like, oh, physicians never got nutrition education in medical school. Well, we really didn't get a lot on menopause or perimenopause either. I actually have a pretty interesting journey. I graduated medical school I went into medical school in 2002. 2002 is when this big study came out with scary findings called the Women's Health Initiative. The Women's Health Initiative said, hey, hormones are bad for us. And immediately all kinds of women were taken off of hormones. So that's what I learned. Hormones are bad for you. We're hurting people with hormones. And the conversation has changed. We've gone back, we've looked at the data, things have been reinterpreted, and I want to make sure that everybody knows that there are people in the Valley that are here to listen to you and take care of you as you go through this transition. It was treating menopause, actually, when I got into training, was pretty taboo. It was more of these kind of rogue providers that were out there. I spent one half afternoon when I was a third year resident, so third year in my training after medical school, the seventh year of my training, with a gynecologist who was doing menopause care. And I was in a practice with a lot of other gynecologists, but none of the other gynecologists were doing menopause care. It was only this one person, and she was only coming in a couple days a week to do it. And so that's what I saw. It was just kind of this rogue thing. Nobody was doing it. It was just kind of this taboo thing. As the conversation got started in the past 5 years, I started taking notice. I started listening to specifically a podcast on women athletes going through the change. Because you can see I'm quite an active individual, and got really interested in it, and started just take more and more courses so that I could help my patients and future patients. All right, so we're gonna get into it. Let me change this a sec. Hopefully this isn't too loud. All right.
And now, the moment you've all been waiting for, the topic no one can get enough of, the very thing everyone wants to talk about, perimenopause! Y'all ready for this? Perimenopause. Perimenopause is the menopause appetizer nobody tells you about. The amuse-bouche to an old bouche. Did you know, because I did not, that in perimenopause, hormones are changing as much and as rapidly as in middle school? Can you imagine if at 45 years old, men's voices started cracking and changing and their facial hair turned back to their fuzzy little caterpillar patches? Can you imagine how quickly science would be like, to the Galapagos we go? Meanwhile, we're over here like, hey, I'm so sorry to bother you. I think I have a swarm of bees in my uterus and my skin's falling off. Could I maybe just, I don't know, talk to somebody about it? And they're all, whoa, whoa, whoa. First of all, calm down. This is nature. For the next 10 to 15 years, your body's going to slowly melt till it shuts the whole thing down and you'll finally be invisible.
Yeah. So I wanted to bring some comedy into this because it just makes lectures more interesting. But she had a comedy comes from truth. Oh, of course, this start off. Okay, sorry. Technology. Yay. Okay, so let's define perimenopause. So we can't define perimenopause until we define menopause. So menopause is when your ovaries have finally given out, said, I'm done, I'm not going to give you any more eggs, and you've gone 1 year without a period. That's the definition if you look it up. That's literally 1 day. Menopause is 1 day. Every day after that is postmenopause. But we all talk about, well, I'm in menopause, right? No, you're actually postmenopausal now. Congratulations, you're after. It's all done. So everything before that is, of course, perimenopause. So peri is the Latin root for around menopause. And so it's actually the changes that start before that happens. I'm going to take you through why that happens. So, of course, we're all made to just reproduce and make the population bigger. And that's actually what our cycles are for. Let me get my laser pointer going here. So a lot of people don't know this, but we're actually born with the amount of eggs that we'll have in our ovaries. And it's about 1 million eggs. By the time we reach puberty, somewhere in here, we're down to about 300 to 400,000 viable eggs. Sorry, I'm saying an open mouth over here.
Of course, it's me. You learn something new every day.
So most optimal fertile years, puberty to early 30s, and we're down to 100,000 eggs. Our fertility then continues to decrease By the time we're 40, the quality of our eggs is down. We're only at about 500 to 10,000 eggs. Over our lifetime, we'll only produce about 450 to 500 quality eggs that will actually will ovulate and could produce a pregnancy. And then in our 30s, we start to get this drop off. So moving on, this is, I love this picture. This is the endocrine dance. So we can't really talk about the ovaries and menopause without looking at the whole endocrine system. Now, an endocrine lecture will be a week long. We're never going to go into every little tiny detail on this, but I just wanted to give you an idea of what the endocrine glands were. So in the brain, we have hypothalamus, the pituitary gland, the pineal gland, thyroid gland in the neck, thymus gland in the chest, adrenal glands are on the backs of the kidneys, our pancreas sits behind the stomach, and then, of course, our ovaries. The primary players are hormones at this point in life are estrogen and progesterone, and then produced from the ovaries, and then luteinizing hormone and follicle stimulating hormones, so LH and FSH, that are produced by the pituitary gland. So it's a conversation that happens every month through our cycle. If you've never seen this picture before, you may have, maybe in middle school or high school, but this is actually what happens. Our body will start, a woman's body will have, the first day is the first day that the cycle begins, is the first day of bleeding. And the body is already preparing for the next chance of making a baby. So it's starting to recruit follicles from the ovaries, grow these follicles, mature them. And you can see down here, we have hormone levels that do this dance each month with each other. The blue line here is our estrogen. So as we start to build up through the month and develop our eggs, the estrogen levels will rise. Right before ovulation, the estrogen levels start to drop. Progesterone through this cycle will be fairly flat. The pituitary goes, hey, ovulate. Then we get the surge of what's called luteinizing hormone, or LH, and it will drop as the estrogen starts to drop as well. And then progesterone comes in. Progesterone is our pregnancy hormone, and it's kind of the glue that holds the lining of the uterus together. The lining of the uterus loves progesterone. It's actually produced by the part of the egg that had just developed. It's that egg that just ruptured creates this thing called a corpus luteum, and progesterone gets produced from this. And it's hoping, beyond hope, that it sees a spermie and they meet up and they make a beautiful baby. If it doesn't happen, it goes, all right, darn, everything starts to drop, and then the whole cycle happens again. So this is women who have, there's some other conditions that don't have this, but this is a usual, what we call normal cycle. A lot of people ask about, I want to put this out here, but a lot of people ask about getting hormone levels and things. So if you do need hormone levels, the best time to do hormone levels is actually while things are fairly flat. So the kind of day 2 to 5 is good for testing FSH, LH, and estrogen. And the best time to test your progesterone is around day 21. So I just wanted to point that out while we're on this slide. And then, hello, perimenopause. What starts to happen is as our ovaries start to produce less and less eggs, they actually get a little hard of hearing. Remember that picture I showed you? The pituitary goes, hey, ovaries, let's produce some eggs. So the pituitary is talking to the eggs going, hello, Bueller, anybody there? And the ovary just can't hear them anymore. So you'll get these surges of estrogen, you get these drop-offs of estrogen, surges of progesterone as the conversation is trying to continue, but the ovaries are just getting kind of tired, like, I've been doing that for a while. I'm not going to do that anymore. I'm just going to slowly dwindle away. So you'll actually see this rise in FSH and LH. And this is, so you'll see the line here, menopause. some of the hormone testing that we do to kind of to see if someone is in menopause will be more actually these hormones that come from the pituitary, because we know that the ovaries aren't listening anymore, and the pituitary is putting out all of this effort, throwing out its FSH, going, come on, baby, give me some estrogen, and it just doesn't. So is that understandable? It's kind of,
Yeah.
Endocrinology is always a backwards discussion. One level goes high, the other one goes low, and just knowing which one is talking to the other. Okay. This is just another representation of what can happen. So this is that kind of over a 7-month period of time. You can see estrogen up, down, up, down, up, down, no particular pathway. Same with our progesterone. Hormones all over the place. They've come through as far as much as I like, but many women fear the word menopause, so I prefer to call it puberty part 2. One more representation of what happens to our hormones. And this is actually a pretty interesting representation. So in the teens, you know, I don't remember my teens, but if you do, I'm sure there was all this weirdness going on, our estrogen, our progesterone dropping. We didn't know what was going on. And then we go into this nice cycle, we cruise through life, and then all of a sudden, bam, things start to drop off. You can see what actually happens is at the beginning of perimenopause, you start to get a drop in progesterone. So that's the first thing that starts to happen. And then estrogen is a lot more volatile. And then you get these kind of surges of progesterone, and then flat line. I wanted to point out on the screen, a lot of people talk about at this time of life something called estrogen dominance. I'm sure a lot of you have heard that term. Oh, I'm estrogen dominant. It's actually, it's not that you're estrogen dominant, it's that your progesterone is dropped. So I know this represents that, you know, your estrogen levels are up here, but really the estrogen levels are really more like right down in here, and then the progesterone starts to drop off, and then you can start to get this imbalance in your hormones. So when people patients come in to me and go, I think my hormones are imbalanced. I'm like, yep, you got it. Sure is a thing. All right. I like funny slides. So here's the board game. We're going to dig into this a little bit more and talk about what our experiences are. So when does it happen? How will it affect me? How do I know when I'm in perimenopause? How does my doctor know I'm in perimenopause? So when this happens, women can actually start getting symptoms in their 30s. They're a little bit harder to know that they're actually in perimenopause. We think more probably around age 45 is when a lot of women will really start to see some symptoms, but it can happen as early as the late 30s. Menopause usually happens sometime between 51 and 50, but remember, that's only one day. So every day up until that. So the average length of perimenopause is about 4 years, but it can be anywhere from 2 to 10 years that women actually experience symptoms. So perimenopause, potentially a 10-year time period, 1 day for menopause, and then the rest of our lives we're postmenopausal.
Start that tax service.
Our symptoms can be all over the place. Periods get weird. You have mood swings that make no sense, hot flashes, night sweats. You can't get out of your own way. Your brain starts short-circuiting. Sleep becomes, well, complicated. You can get brain fog, forgetfulness. This comes from that fluctuating estrogen that can affect our memory, our focus, our verbal recall. And a lot of us start to feel not as sharp as we used to do. We can get weight changes, we start to get vaginal dryness, just general mood changes. Okay, more fun because I'm talking too much. Sorry. And come on, computer, you can do it. There we go. And slideshow. All right. So symptoms.
Dude, you okay? Totally. When I actually die, some people are going to get seriously haunted. I'm mentally unstable. Why? Why me? That sandwich was the only good thing going on in my life. Someone aged, the only good thing going on in my life. My life is an embarrassment. I should just go live under somebody's stairs.
Not getting Oregon.
It's like a peach. Totally fine. Why it's put out all loud and squeaky, because really, I'm fine. What the hell happened? What the hell did what?
Someone when to shut up.
Yep. Answer that right now. I'm still carrying a little holiday weight. Why do bad things happen to good people? Man, can't anything go right in my life?
Thanks for putting up with my fun. All right, get back to the slide we were on. All right, so symptoms. Okay, so we listed a few symptoms, but in reality, if you search on the internet, supposedly people have come up with at least 100 symptoms that we can get in perimenopause. So let's start at the top. Brain fog, difficulty concentrating, headaches, migraines, hair loss, irritability, mood swings, hot flashes, anxiety and depression, dizziness, gum problems, burning mouth, changes in body odor, irregular heartbeat, breast pain, night sweats, brittle nails, fatigue, weight gain, allergies, insomnia, joint pain, bloating, digestive problems, tingling, extremity distress, incontinence, which is leaking, osteoporosis, loss of sex drive, electric shocks, irregular periods, vaginal dryness, itchy and dry skin. And that's not all. These are the fun ones. Taste changes, phantom smells, ringing in the ears, acne, hair where you don't want it, bladder infections, constipation, dry eyes, rage, panic attacks, ADHD. Women who have had undiagnosed ADHD, we actually start to see it because we don't have the coping mechanisms of our estrogen and progesterone. Painful joints and muscles. I've had women come in with such bad joint pain from their estrogen that it looks like they just got diagnosed with rheumatoid arthritis, that just kind of debilitating everywhere pain. And of course, fatigue. I had to come back to that one, but that's probably the number one I hear. All right. So what will be your experience? Everybody has their own perimenopause experience, and that's the hard thing. Nobody comes in and it's not 5 things and hot flashes, fatigue, my vagina's dry, and I have to sleep on time. It's not that. It's all of these things. So it's a wild, wild west out there of what your experience will be. I searched for some terms of what people describe their perimenopause experience was, a zone of chaos. Some women, oops, I haven't had a period for a year. I guess I'm there. No symptoms, fine, you know, no big deal. The good, the bad, the ugly, rocky road to menopause, and what fresh hell is this? Unfortunately, this happens usually in our mid-40s. This is when our kids are teenagers and their hormones are raging. So our hormones are going like this, their hormones are going like this. So good luck, guys. Our parents are aging. They're getting into their time period where, okay, we're taking care of the kids, we're taking care of our parents. We have, this is usually, you know, you've been in a job 10, 15, 20 years. There's potential, you know, work stress, trying to balance all of these things. It's just not fair. All of a sudden, we don't feel like ourselves. We can't juggle what we used to be able to. We don't have the motivation to go to the gym like we used to. Sometimes we bleed twice a month. It's just whatever. How do you know you're in perimenopause? Anybody know?
Can't eat hot food anymore.
I can't eat hot food anymore. Who knows? Right? Who knows? There's no one test. There's no list that'll tell you exactly. It has to be a suspicion by you and your doctors. And that's where women don't feel like they're heard, because they'll go to their doctor and they'll bring all these symptoms. And if their doctor doesn't have a high level of suspicion for women of a certain age, they'll go, oh, you're fine. It's just stress. You're just depressed. It's just anxiety. It's okay. So that is the problem. And I was definitely one of those providers. I'll tell you, when I first got into my training, I didn't know enough about this, and it wasn't talked about, wasn't taught. So I'm here to tell you, I'm sorry, and I'm here to hear you now, and let's get this taken care of. I wanted to bring you back to this, remind you that there's no blood test. I've heard some people go, oh, you should go get your hormones tested, and that'll tell you. Where are we gonna tell it? You know, where am I gonna get my hormones checked? So it's, you know, there are some caveats as to when you can get your hormones checked and have an idea, but 90% of the time, hormones aren't necessarily needed. Oh, wrong direction. So to help yourself and help your others, you're here. You're going to tell your friends. You're going to educate yourself. You're going to actually start paying attention to yourself. You're going to track your symptoms. You're going to track your sleep. You're going to track what treatments you've already done. By the time people get to me, a lot of times they try this, that, the other supplement their friends told them about. Track your exercise, track your cycle. That's the big thing too. That helps us kind of figure out where you're at in this process. Come on, computer. There we go. Style points. So I have a lot of patients come into me, and they'll be there for their wellness visit. And for a wellness visit as a physician, there's 20 things I have to get to. If you want to find out if you're in perimenopause, menopause, postmenopause, if you want to talk about this, skip the physical, come in, say, I want to know what's going on with me. Ask the receptionist when you call in, hey, I have a lot of questions. I think I need a longer appointment. So these are the style points for either me or some other provider. Make sure you make room for being heard at your provider. Come fasted. Sometimes we want blood work because this is not always perimenopause. Sometimes it's hypo, which is low thyroid. Sometimes it's high thyroid. Sometimes it's other things going on. So we're always thinking, could it be something else, and ruling out the things that it could be. So if you come fasted, then we can get the blood work done right then. Bring the data. So do your tracking, bring your data. And like I said, don't squeeze this in.
So Nikki,
Yes.
family history, right? Is that what your FH is? Family history?
Yeah, sorry, it's family history as well. If you bring in your family history, that may help us out.
And what do you want as far as family history? Just like menopause
No,
or?
No,
or
I
just
want
everything?
medical
Okay,
conditions.
just
So
everything.
for others, sisters, what are their health conditions, mom, dad, and then kind of first grandma, grandpa, I don't need fifth grandpa or great grandpa fifth removed, you know, that sort of thing. If you're not being heard, it's okay to go and find somebody else. If somebody says you're too young to be in perimenopause, if you've come to a lecture like this, you've read the books, you've done the Googling, you've watched the funny videos, you're like, I'm in perimenopause. You might be. If somebody says you're too young for this, find another doctor. If your provider says I don't prescribe hormone therapy, find another doctor. There's specific time limits set on your treatments. So they say, okay, I'll give you this, but you're only going to do this for 2 years. Find another doctor. And especially if this is just something you're going to have to put up with, this is natural. Find another doctor. All right, so you've decided, you've done the research, you've done the lectures, you're ready, you know you're in perimenopause. What now? There's lots of things we need to go through. So do you need contraception? What are your most bothersome symptoms? Do you have irregular bleeding? How's your current health? What is your lifestyle like? So we're going to dig into each of these. Contraception. So I took a course recently, and the first thing the provider asked the patient is, do you need to be protected from sperm? Okay, kids, you are listening. It's funny, but that's basically what contraception is, right? Do we need to protect an egg and a sperm from meeting? And contraception is still a thing, and then in perimenopause, specifically what we're talking about today. Because in early perimenopause, I put a little squiggly 10%. In early perimenopause, like the first 2 to 5 years, there's a 30% chance of pregnancy. In the later years of perimenopause, there's a 5 to 10% chance of pregnancy. So it's still a possibility. And so it's still something that needs to be in your mind's eye. Management choices are the same as they were before perimenopause. All kinds of different options for contraceptives. Some great ones for this time of life are oral contraceptives and intrauterine devices. Now I'm not going to go into the nitty-gritty on every particular possibility, because like I said, everyone's perimenopause journey is unique, and you need to find somebody who understands this, and you can have a conversation and come up with the right treatment for you. But all of these treatments are out there. If permanent options have already happened, then great. And there are other options such as there's a little device that you can have placed into your fallopian tubes. I don't know if anybody at Star Valley does it. Do we? Okay, great. But this needs to be on the forefront. This a lot of times gets forgotten because we think, oh, we can't get pregnant at this point in life. Irregular bleeding. One of the main irritating symptoms, especially in early perimenopause, middle perimenopause, is irregular bleeding. So how do we control that? Because it can be super heavy now. It can be twice or 3 times a month instead of once a month, especially in early perimenopause, because remember that drop off. So progesterone starts to drop. And what's progesterone do? Progesterone actually holds the lining of our uterus together. It's the glue of our uterus. And if we have a drop off in our progesterone, we're not going to have the lining of our uterus protected. And so that's when the irregular symptoms start. In the beginning of perimenopause, our periods will start to get a little closer together. And then we get a little more mid-perimenopause, they start to spread apart a little bit. And then you'll actually start skipping months. You get into late perimenopause when you've actually gone about 60 days without a period is the definition of that. The reason I bring up contraceptives is a lot of people will feel like they haven't been heard if they go to the doctor, they say they have irregular bleeding, and they're sent home on a birth control pill. Birth control at this point in life is hormone therapy. And that's not really out there in the world. It's just, oh, well, they just dismissed me. I don't need birth control. You know, say your partner is out of vasectomy or something. I don't need birth control anymore. Well, we're not using it for birth control. We're using it to help you with your symptoms. And birth control can be one of the great tools, especially for irregular bleeding. Another great tool is an intrauterine device that has progesterone. It has to have the progesterone. It can't be the copper, because the progesterone, again, is the glue of the uterus and calms down the bleeding in the uterus. It can be an amazing tool at this time of life, because depending on which one you choose, it can last anywhere from 3 to 8 years. Technically 5, but I've had some women go 5 for bleeding, 8 for contraception, but I've had some women go into 8 and still not have any issues with bleeding. You can get the lining of your uterus burned, which is called an endometrial ablation. And then an option is also hormone therapy, and we'll talk about that more in a sec. I wanted to breeze through. I had such a hard time actually putting this lecture together because there is too much to talk about. And like I said, everybody's experience is unique. So I didn't want to pigeonhole anybody into, okay, this is this treatment, that's that treatment. So I wanted to give everybody a broad overview and make sure that everybody at least knew what perimenopause was, had the resources when you walked out of here, and knew what to ask your doctor. So lifestyle is a big part of this. So again, we get into perimenopause and this is what we're doing in our lives. There's some big points in my patients' lives when I've seen them that there's usually a time where I can convince them to really take stock and make a change. Unfortunately, it ends up being when there's some sort of medical emergency or life-changing diagnosis. And so I would encourage everyone to think of our perimenopause journey or menopause journey as our body's starting to change. This is the time that we should actually start pausing and taking care of ourselves. Hit the pause button. We're in perimenopause and see what you can do to take care of yourself. Nobody takes care of the person in the middle. We're juggling everybody else around. Take the time to take care of yourself. hit the pause button, reassess. So lifestyle, stop smoking could be the number one. Smoking actually increases our hot flashes. People who smoke will go through menopause 2 years earlier than others, and so they actually drop their hormones earlier. Stop or greatly reduce alcohol use. Alcohol interferes with our ability to sleep. I alluded to earlier that sleep was one of the main symptoms that I hear of people having issues in perimenopause. I'm gonna go into that a little bit more. A lot of women will come in, you can still fall asleep, but you can't stay asleep. Anybody? You can't stay asleep, you're up at 3 a.m., you're just laying there, your brain has decided it needs to do something. That's the drop in your progesterone. Our progesterone is our calming hormone, our rest hormone, and that's what we experience. Some women actually get they can't fall asleep and they can't stay asleep type. But alcohol specifically interferes with our deep sleep. It will raise our cortisol levels earlier in the morning, and so we'll get a double whammy. We don't have enough progesterone. Our alcohol actually wakes us up because it makes our cortisol rise. So if you do enjoy some drinks with your friends on the weekends, try to separate it by about 2 to 4 hours before you go to bed, and that will help a little bit. But it can also increase hot flashes, can contribute to weight gain at this time, can worsen your mood swings. And I don't know about you, but the hangovers aren't as fun anymore. Know your numbers at this point. When you talk to your doctor, you want to know where your blood pressure is at this point in your life, what your cholesterol numbers are. Check for diabetes, pre-diabetes. I put in all the options for weight here. What's your weight? What's your BMI? What's your waist to hip ratio? What's your body composition? We can go into, we could do a whole day on what's the best way to measure your weight, but start paying attention to your numbers. Okay, lifestyle. These are the things that get listed for lifestyle, right? Prioritize sleep, exercise, watch your nutrition, make time for community, stress reduction, pharmacology. If you actually look into what's called the American College of Lifestyle Medicine, these are the 6 pillars that they focus on, not the pharmacology part. But getting rid of toxins would be their 6th one. For pharmacology, we're going to talk about supplements, hormone therapy, and non-hormone therapy. A lot of people come into me and go, I start mentioning these things, go, I'm already doing this, doc. I don't need to talk about that stuff. Just give me the drugs. But again, you may be doing something, and it was something that works for you in your 20s and 30s, but it doesn't work anymore because our bodies have changed. The physiology is changing as our estrogen or progesterone drops. So again, reminder, pause. You have to reassess at this time of life. Give yourself a hug. Take care of yourself. And this is one of my favorite sayings for my patients. If you don't make time for your wellness, you'll be forced to make time for your illness. So pause, take care of yourself. This is the time to reassess. Okay, let's dig into each lifestyle issue quickly. Again, sleep could be a whole week of lectures. And sorry, I didn't have any. I was just going to talk here. No screens an hour before bed. No exercise right before bed. Make sure your room is dark, get the temperature right, hot flashes, night sweats. There's all this cool stuff out there now. Cold jammies, cold sheets. There's pads that you can buy that are actually cooling that you can put on your side of the bed. Fans, lower the room temperature. Do something lovely and relaxing right before bed, a lavender bath. Actually, if you take a hot shower, it'll actually kind of trick your body a little bit. Read a book, do some breathing exercises, a little guided meditation, a little magnesium can help at this time of life. Nutrition. A lot of people will come into me and go, I haven't done anything. I don't eat anything. Well, a lot of our weight and our health at this time is 80% diet, 20% exercise. So most people come into me and say, I just need to exercise more. I'm like, no, we just need to see what you're doing diet-wise. And again, this would be 5 lectures in one. I'm just going to go through some overreaching general principles that you could focus on. So anti-inflammatory, whole foods, plant-based diet, Mediterranean diet is considered the best diet for us. This is actually researched in terms of our brain health as well in menopause. I'll get to some resources at the end. We do need more protein at this time of life. You'll see a lot of funny things out there like, I am eating my protein, I am eating my protein. So women who aren't really active, they need between 1.3 and 1.6 grams per kilogram per day, depending on the source that you find. So that's for, I did a like 120 to 150 pound women, so 90 to 110 grams of protein a day. If you look at that, that's broken down to like 30 grams per meal with some snacks in there, or 20 grams per meal, some snacks in there. Athletes need a lot more. We can't build our muscle like we used to because estrogen actually interferes, a drop off in our estrogen actually interferes with that process. If athletes find that they're not able to do what they could in the gym, or can't climb that peak like they used to be able to, or can't ride their bike as fast as they used to, then there's actually a physiologic reason for it, and we actually need a little bit more protein. So 30 to 40 grams of protein per meal, less of doing snacks. Limiting your sugars, so 25 grams of added sugars per day or less, and 25 grams of fibers per day. You're going to ask where are the carbs, where are the fats? If you focus on protein, if you're limiting your sugars, and then you focus on fiber, everything's going to kind of fill itself in. I don't need you to track 100 or all three macros and count every single thing going in your mouth. Not a specific calorie count that I want you to focus on. And again, everybody's perimenopausal journey is different. So this is just a broad overview. If you haven't done anything, you can kind of work potentially towards this, and then work with your provider or your dietitian. Exercise. Everybody comes in and goes, I've been doing the same thing that I usually lose weight with, and it doesn't work anymore. Well, yeah, your body's different now. So you actually have to change it up. So what worked for us before doesn't work now. A lot of women will do what's called fasted exercising. And so they'll get up in the morning, pound a coffee, go to the gym, not eat anything, work out for an hour, do high intensity exercise, do their Zumba, their weights, whatever, and then not even eat maybe for another hour later. They're gonna run home, get ready for work, make sure the kids are ready, and then maybe eat. Well, that doesn't work anymore. So you need to make sure you fuel for your exercise. 100 to 200 calories before you go work out of something, a little protein, a little sugar, and then fuel during exercise if your workout's going to do more than an hour, and then make sure that you're eating within 30 minutes of your training. Your type of training needs to change. A lot of people, we've been taught cardio is the thing. If I run, I'll keep my waistline. Doesn't work anymore. We don't need to do the hours and hours of cardio that worked for us in our 20s and 30s. Transitioning to something called hit and sit training instead of our hours of cardio 1 to 2 times a week is more effective. And then resistance training. These are the keys. If you're not working out, if you don't do any exercise currently, then this is not where you're going to start. This is someone who's already active and already out there doing their thing. And resistance training is not just going to the gym, grabbing your 5-pound weight and doing 50 arm or bicep curls anymore. We were taught when we were younger, low weight, high rep. You don't want to bulk up. You want to look slim and lean. That's not a thing. We need to actually load our muscles past our perimenopause and our menopause time. Because if we don't load our muscles, because of our drop in estrogen, our muscles actually won't respond. So there's actually been studies showing if you do higher weight, lower rep, you will be able to maintain your lean muscle mass. So there's a lot of controversy. Zone 2 or HIIT training. The individual that I feel is doing the the correct research out there. She's the last one on your pink paper there, Stacy Sims. She's actually an exercise physiologist doing research on women in menopause, perimenopause, and her research shows HIIT and sit training, not zone 2. Zone 2 is a place where we can start. If you're not exercising, zone 2 means you can go for a brisk walk with your friends, but you can still talk while you're doing it. And so if you're not exercising at all, this is where you start. But if you're that lady with everything up in the air and you don't even know where you're going to start, you're going to actually just start with going to some yoga. Just start moving your body. Just start doing some meditation. Just start doing 10 squats at work in between every hour, and so that you could do some get off your butt for a little bit in your day. So if you've not exercised, it's important to get into exercise with the consent of your doctor, is always what the commercials say, right? But you do want to make sure that you're healthy enough to get an exercise. And then sometimes it's good to just hire a trainer or find a YouTube video that doesn't seem too taxing. There's a lot of free stuff out there, but start low, go slow. Don't go right to the gym and lift 90% of your, what we would consider your max body weight. Balance training. So balance training, brushing your teeth, stand on one foot, change your hand, do the other side. Learning how to put your shoes on with your leg up in the air. This will actually keep you healthy. So you pick up your shoe, probably not gonna be able to do it with this jacket on. You put your shoe on. You do the same on the other side. Put your sock on. Do some balance training. Don't sit down to put your shoes and socks on. Find some time in your day. Commercials while you're sitting watching at night. Get up, balance on one leg. For half the commercial, balance on the other leg with the rest of the commercial. If you're already athletic, this is when you actually have to start slowing down and prioritizing your recovery. If you are used to just going to the gym 5 days a week, I could do an hour of HIIT or CrossFit or weights, and I was always fine. You go to the gym now, you do one workout, it takes you 3 days to recover, right? It seems nuts. This is actually a thing because we don't recover as fast. So this is where shorter cardio, couple days of resistance training, do one leg day, one back day, core day, one upper body day, and then prioritize recovery. On your off days, do some gentle yoga, do some breath work. The other pillars of general health include digging into your community and stress relief. Social and community connections actually affect our physical and mental and emotional health. Again, this could be a whole lecture in itself. Just trying to give everybody a big overview. Get out into support groups, find blogs, find friends of the same age going through this, go on walks, book clubs. Right, Wendy? Yes. Stress. This is the time to start learning different tools for stress. Again, another lecture all in itself. But we can actually change how we think about stress and react to it. Supplements. There are probably 20 other supplements that we could go through. These are some basics that are not dangerous to try on your own. A lot of people think supplements are benign because they're sold over the counter, everything's okay. So these are the ones I felt comfortable sharing with everybody. So some vitamin D, B12, omega-3s, focus on probiotics. Our estrogen decreases. We actually, the physiology of our bowel health changes. Our gut microbiome, right? That's a big plug word right now. It's a real thing, but we're just learning about it. We're just learning how to deal with it. But if we actually look into the physiology, as we drop our estrogen, the microbiome, the type of bacteria in our gut will actually change through perimenopause and menopause. And so these are good bacteria to look for in your probiotics, specifically lactobacillus species. a little bit more helpful with say vaginal health. Bifidobacterium is better for our gut health. Lots of other supplements, but I really encourage you to talk about it with your provider and not just go and find the newest fad out there and start taking something without advice. Okay, hormone therapy, probably one of the big things that a lot of people have questions about. I want to just go through the different hormones and what they actually help you with. So estrogen is when you get a drop off of your estrogen is when you see your cognition changes, when you see the vasomotor symptoms, hot flashes, night sweats, and genitourinary symptoms, so vaginal dryness, pain with intercourse. Estrogen or supplementation can be for those people who are hot and dry. Okay, hot and dry. Progesterone, we talked a little bit about earlier, is kind of our calming. It's the glue of our uterus. When our estrogen starts to drop, we start to feel more anxious, start to have the sleep issues, and start to have a bleeding irregularity. It can help with endometrial protection. So if women do want to be on hormone therapy, you do, and you have a uterus still, if you haven't had your uterus removed for some other reason, then you do need progesterone for endometrial protection. What that means is if you do ever go on hormones and you still have your uterus and someone puts you on estrogen for a long period of time by itself, it can build up the lining of the uterus and contribute to cancer of the lining of the uterus. A lot of people will start one hormone at a time so they can see how you react to it. And so if you start estrogen for a couple months by itself, that is totally safe. It's not dangerous, but you just don't want to do that for your whole life. You want to have the estrogen, make sure that whatever you were started on helps you. If you need to change it, fine, talk to your provider. And then progesterone can be started. The other hormone that a lot of people have questions about is testosterone. Testosterone does decline as well with perimenopause. Our ovaries make the majority of our testosterone, but our adrenal glands actually make testosterone as well. So we don't get a flat line of testosterone as much as we do more of our estrogen and progesterone. So testosterone is helpful for some women. It's more, it can be for bone health, but that's not an indication. There's some studies out there that are suggesting it, but it's not an indication yet. It can help sometimes with cognition, mood, libido, general physical energy. The only reason to start it right now is this, in terms of FDA approval, something called hypoactive sexual desire disorder is the only FDA approved indication. The only FDA approved indication for estrogen and progesterone is hot flashes, night sweats, vaginal dryness, and osteoporosis prevention. That's the only reason why we're allowed to prescribe this, but we prescribe these hormones all the time for what we would call off-label indications, which are listed up here. Other medications that can be helpful, that are medications that are not hormones, these are antidepressants. A lot of women have had the, in say the past 10 to 15 years, have had the experience of they go into their doctor, they come into these symptoms, and their doctor says that they're anxious or depressed. So they leave on an antidepressant. It's not completely out of the range of wrong, because what actually happens in our brain is as our estrogen drops, our serotonin levels drop as well, because estrogen supports our serotonin levels. And so it's not wrong. It isn't off-label. There's only one hormone, or sorry, antidepressant, which is approved for depression. For menopause, and it's low dose Paxil under a different name. But these can also help with hot flashes. So it's not out of the range that these can be used. Gabapentin is an anti-seizure medication that can help immensely with hot flashes if someone can't take hormone therapy. Oxybutynin is a muscle spasm medicine for our bladder that can help us if we have any leaking, but it can also help hot flashes. Clonidine is an old blood pressure pill that can help hot flashes. And then this is called fezolinetant, which is a Veoza. This is a new medication that they developed. Remember that hypothalamus pituitary thing up here that I showed you? This actually talks directly to that area and helps balance the hot flashes through that mechanism. Okay, we're definitely gonna run over. A lot of people I figure would have questions about hormone therapy, so I wanted to go through some benefits. None of these are FDA approved reasons, like I said, but symptom relief, improved quality of life is the number one thing I see with hormone therapy that we don't really take into account. It's one of my favorite things to do. I have someone come in with all the symptoms that we listed. They go home on a little hormone therapy, they come back in, and they go, oh my gosh, I feel like myself again. Like, I love that. That's what I want to do. Hormone therapy can reduce the risk of osteoporosis, reduce the risk of diabetes, reduce the risk of coronary artery disease, reduce the risk of dementia. This one's has some caveats. This is more for people who the studies have shown people have a gene carrier for increased risk of dementia called ApoE. The study that actually says this shows those individuals and hormone therapy started early, it can have a decreased risk of cognitive changes. This particular, I'm going to get to that second one. So reduction of macular degeneration, reduction of depression, and this one here, reduction of all-cause mortality. This means all reasons for us to die was reduced if we start hormones. And this is specifically all of these where if we start hormones within 5 to 10 years of our menopausal change. So that can be before menopause, that can be after menopause. There's also a lot of questions that come up about this. So there's something called the timing hypothesis. If we start these hormones within 5 to 10 years, that's where all these benefits come from. But if we start the hormones greater than 10 years, specifically cardiovascular disease, they saw there's not really a significantly increased risk, but if it's greater than 20 years, there was actually an increased risk of cardiovascular disease with hormones. So this is where the controversy comes in right now with hormone therapy and when to start. So if you feel like hormone therapy might be right for you, then 5 to 10 years is kind of that key window. And then if you start hormones after 10 years from menopause, the all-cause mortality, so this reduction in all-cause mortality, that goes away, and we actually have an increased risk of death after starting hormone therapy. We don't have a direct explanation of that. And then if women start hormones 65 to 79 years of age, and they already have some some changes of cognitive decline of dementia, it will actually make it worse. So those are the caveats. So these benefits, these preventative type of processes are if you started hormones within 5 to 10 years of menopause. Oh, sorry, I forgot I put this up there. All right. The other big question that we get is breast cancer risk and hormones, because like I started with, I went into medical school in 2002. The Women's Health Initiative was stopped because there was a risk of breast cancer came out. And what actually they showed, and I'm going to pop this up in just a sec, but there are 3 arms of the Women's Health Initiative. There's an arm over here that women didn't get any hormones. The arm over here that women got estrogen, and then the women in the middle that got progesterone and estrogen. Those are the women that still had their uterus. They did find that there was a slight increased risk in those middle women who took progesterone and estrogen. It was a synthetic form of progesterone and estrogen, and it was in women who were older. The Women's Health Initiative average age was 62 because they wanted to enroll women who didn't actually have symptoms of menopause. So there's a lot of wrongs that happened with this study. But the biggest wrong is that in 2002, they announced that there was increased breast cancer risk and all these women got taken off their hormones. What they actually found was in this middle category, the 2 hormones, there were 5 women out of 1,000. Over here in placebo, there were 4 out of 1,000. So they called that 26% increased risk. That was relative risk. Sorry, that was absolute risk, not relative risk. Relative risk was 0.08% increased risk. That's the number we care about in medicine, 0.08% increased risk. So they scared the crap out of all kinds of women. And we still talk about it. I'm still, every day, my patients come in and go, "You're not gonna give me breast cancer, right?" And then I liked this, sorry, and then the estrogen over here, they had a decreased risk of breast cancer, estrogen only. Kind of cool. Women who drink more than 2 units of alcohol per day have a 5 out of 1,000 risk. You talk about the 4 cases. I couldn't find a cool one from the US. Sorry, this is UK. The UK has all kinds of fun info. Australia has all kinds of fun info. So current smokers, increased risk. If you exercise, you can decrease your risk of breast cancer. And then this talks about the 4 cases. All right. So everybody's scared of breast cancer. Because what? Cancer, right? Oh my God, big C. And boobs, right? Boobs, cancer, we don't want those together. Heart disease is what I really want you to be scared about. Because heart disease is the #1 killer of women. Over 400,000 women will die from breast cancer in a year. Anybody know that? Breast cancer, I'm sorry, of heart disease. I said breast cancer. 400,000 women in 1 year will die of heart disease. 6 million women live with cardiovascular disease, so that's strokes, high blood pressure, coronary artery disease that have not killed them yet. All cancers, lung cancer is the #1 cancer killer, 60,000 deaths per year. Breast cancer, 40,000 deaths a year. 400,000, 40,000. Cancer's scary, it sucks. I don't want to go through it. I don't want my friends to go through it. But heart disease is what we're going to do a next lecture on, right, Wendy?
Yeah.
So I want to point that out because we get so emotional about cancer and boobs, but heart disease. If we don't have our heart, we can't run the rest of it. So start taking care of yourself now. Quit smoking, decrease your alcohol, start exercising, do the nutrition bit, get stress relief. Okay, there's usually a lot of questions that come up when I go through some hormone therapy. I wanted to go through potentially head them off at the past. We talked about hormone levels and testing. There are definitely some times when you should get hormones levels tested. So what happens if a woman has one of those cool IUDs I told you about, and they don't actually have a period right now, and they're having some symptoms? That can be a woman that we might want to do hormone testing on, or a woman had their uterus out because she had horrible fibroids when she was younger, or she had some sort of emergency during a pregnancy, something like that. That's a woman that could have hormone testing. Once you're on hormones, there's reasons to have hormone testing done, but it's not something that everyone has to get just because you have some symptoms. Hormone therapy is not dangerous. If you do ever go on hormone therapy, there is a black box warning. It's really cool. It says you will die from this. This is an old thing. The proponents of women's healthcare now actually have a campaign to try to get the black box warning. It's on progesterone and it is on estrogen. So just an FYI, hormones are not going to kill you. There's actually significant benefits as we went through. A lot of people ask me about bioidentical hormones. Bioidentical just means it's similar to what our body makes. There are 3 types of estrogen in our body: estrone, estradiol, and estrione. E1, E2, E3. E2 is our main hormone that we live in for the majority of our life. So E2 is our bioidentical hormone that we replace with hormone therapy. It's called estradiol. So if you get an estradiol prescription, that's your E2, and that's your hormone that's as close to bioidentical as what you had naturally from your ovaries. And guess what? There's about 10 different formulations that are approved that you can get through your insurance. Where the confusion comes in is in the past 20 years, bioidentical has been only thought of as something you have to go to a compounding pharmacy and get specially formulated for you based off of the saliva and urine test that you just had done. That's a misnomer. You don't have to do that. So bioidentical hormones There's several FDA approved versions that I prescribe every day, several other providers prescribe every day, and can help you. But these are the ones that you do want to focus on potentially using. There are others that we would call more synthetic hormones. And again, that would be a whole other lecture. A lot of people ask me about pellet therapy. In the training that I had, you have to earn your pellet is what I learned. So because there are 20 other versions of hormones out there, pellet therapy are these little pellets of estrogen, testosterone, progesterone that actually get inserted through an incision, usually into your gluteal area. You can't get those taken out necessarily. Once they're in, you live with the effect for 3 months. And they can be good for a lot of people, but because they're in there, we can't take them out. You can get this big swing in your hormones with gels, with patches, with oral tablets. We can either not have you take that, we can have you rub it off, or you can have you peel it off if you're having a reaction to it. So we have to have kind of gone through all of the options for me until, like I said, you've earned your pellet. So I don't go right to pellets. A lot of people think you have to wait until menopause to start your hormone therapy. That's not true. You can start hormone therapy in perimenopause, and that's something you should talk about with your provider. This is something I want to get the word out there too. So vaginal dryness that happens with perimenopause, menopause, postmenopause can actually increase our risk of bladder infections. Bladder infections can lead to blood infections. Blood infections can lead to death. So vaginal estrogen prevents death.
Vaginal dryness can kill women.
Yes, vaginal dryness can kill women. There are several other options for vaginal dryness, but the education that I got is basically once you start having any symptoms of vaginal dryness, everyone should have a little vaginal estrogen in their lives. So if you don't have any vaginal estrogen yet, ask your provider. Okay. Like I said, menopause has had its time. Perimenopause is starting to have its time. If you're getting overwhelmed in your inbox, on your socials with information, it sounds too good to be true. It probably is. That magic pill is not going to work. You have to do the hard work. You have to do the pause. You have to reassess. You have to change the lifestyle. No magic pill is going to fix the changes. Well, hormone therapy, a little magic, but it's not going to fix everything that's going on with the physiologic changes in your body. Seek out reputable sources, look to reputable medical organizations, and find a provider who will listen. Your pink sheet that I handed out has this information. This is Heather Hirsch. She has an amazing website, heatherhirsch.com. She's a Cleveland Clinic trained menopause specialist. She actually has a course for the public all about menopause. So you can go, I think it's a couple $100. If you're someone who likes a self-help course, she's super interesting and teaches very well. And she has a book, Unlock Your Menopause Type. She's coming out with a perimenopause book in the fall. Mary Claire Haver, thepauselife.com. She wrote The New Menopause. Her goal in life is to demystify menopause. She has a lot of online resources. Have you ever heard of the Galveston diet? She wrote that. And she has a new book on perimenopause coming out in the fall. Like I said, menopause had its time, and now perimenopause is like, what about me? So everybody's switching their gears towards that. Kelly Casperson, MD, she's a board certified urologist who focuses more on women's sexual health, especially through midlife changes. She wrote an amazing book called You Are Not Broken. She has a lot of free online resources. This is a quick listen if you're an Audible person. Lisa Mosconi is another one to have in your mind's eye. She is a neuroscientist who works at Weill Cornell Medicine. If you're interested in donating your body to science, she is doing research on the women's brain and perimenopause and menopause, and doing what are called PET scans and finding what happens to our brain in menopause. She wrote several books. The most recent, The Menopause Brain. I just wanted to bring this up. This is super interesting. This is your brain on drugs, right? Thank you, still with me. So this is before menopause. This is glucose being taken up in the brain. During perimenopause, you can see all the changes. Early menopause and then late menopause. We actually start our brain actually goes through this whole change. We actually start to get a little closer to premenopause, how the brain takes up glucose. But pretty interesting. And this is the research she's doing. She's actually now tracking estrogen receptors and trying to track progesterone receptors as well. So she's one to be watching. This one is a little bit more. Those are a little more, it can be a little more heady. This one's a little bit more of, like she says, girlfriend approved guide to menopause. So very good read, quick listen, talks a lot about lifestyle. If you're active, you have to have this in your mind's eye. You have to be listening to these podcasts. Feisty Menopause, it's a podcast called Hit Play, Not Pause. Nutrition experts, training experts, lifestyle advice for the athletic woman. This is the woman I mentioned earlier that is actually doing the studies on us in menopause and perimenopause around nutrition and diet and lifestyle, exercise, performance. Stacey Sims. She also wrote a book called The Next Level. This is, if you're an athlete, this needs to be in your library. The Menopause Society is a great resource as well. They have a specific, a patient-specific page, and they have a guidebook that you can download. And I'm going to come back to that. I'll finish with this guy. So for our partners, thank you for the guys being here. I don't know if you're going to have any of the right partners, but
Yeah, no.
this, this is for your mothers and your sisters. This is how do we get our partners? So I learned from my patients every day. And last week I had a patient, she came to me and she's like, great, this is awesome information. What do I do to make my husband less of an idiot? And I understand what she was talking about. It's you know, but what I recommend is starting the conversation. This is a letter I found. I totally stole this off the inner tubes. I did not invent this, but I think it's a great starter for how to open up the conversation with your partner, and how to get them involved. I found this last minute, so I actually don't have it on your pink sheet. It's called Shebang. So it's, I didn't love the name, but then I read their moniker: information, tips, guidance to help you support your body, mind, and nervous system through perimenopause. They'll help you feel the whole shebang. So this is an Australian website. Like I said, Australian websites, your EU websites, awesome information. Go to this website. They do sell this latte thing. I can't vouch for the latte thing, but steal all of their perimenopause data. It's awesome. And on the back of this partner website, I actually have, there's, if you go to the, it's the chebangwomen.com AU blogs, perimenopause blog. So if you, and then you could, if you search on their website, this little search thing here, if you search for partner, it will bring this up easily. But it brings up a whole perimenopause guide for your partner and takes them through, it links them to studies from Harvard, it links them to this article, that article. You know, what do we do now? We do all of our research on the toilet, on our phone, right? So point them towards this website and they can do their research. But this is an amazing place to start the conversation. If you don't talk to your partner about what you're going through, you're just gonna go through this alone and not have any support. But if you bring them in the loop, this is the partner guide to menopause. Okay, I'm gonna go back and end with perimenopause, and then we'll get to questions.
It's the role of Brian and Gilmore Girls again, huh? Wait, who are you? Sorry, I'm Terry. Perimenopause. Get out of my house? Absolutely not. I'm gonna be here for a while. How long? 15 years, give or take. You're making me really anxious. You catch on quick. I'm the reason you're feeling everything right now. What do you mean everything? Probably easiest if I just give you this brochure. Oh, thanks. Hold on. First, let me do this for you real quick. Okay, well, Perry, you're making it too dark to read, right? When the light is low. Vision's gone. How am I supposed to read this? Get your little readers, shine the cell phone light. Just be glad I'm not making you drive right now. Be like bumper cars out there making you drive at night. This is just a lot to process. I need a glass of wine. Finally. Let's go. That's a pretty big glass. Here you go. Thank you. And take a big sip. All night slumber party. Me and you, babe. No. I need my sleep. No way. Not with that wine. Now that you've had the smallest bit of alcohol, we're going to stay up all night long. I can't function without sleep. Tell ghost stories because, that triggers your anxiety. And then you'll spend all night thinking something terrible will happen. We will stay up all night. Wine is worth it. That's it. You know what? I am going to go put on my PJs. Just make sure to do it in front of a well-lit mirror. Why exactly? So when you get undressed, you can see how this changes that made your body. Yeah. My best work, really. Yeah, I weigh the same, but nothing really fits. It's really a gift. I can just shift everything around. I exercise, I eat right, and nothing, right? And that's not acne. And why am I breaking out again? The hormones of a teenager without the metabolism. Chef's kiss. None of this this feeling of impending doom and irrational thoughts will start soon. Are you getting emotional about your daughter leaving for college soon? She's not leaving for 18 months. Here come the mood swing. Whatever. This is so fun. The panic mixed with the depression. Let's get you tucked in. I'm going to the doctor tomorrow to get rid of you. Oh, that's fine. I mean, most doctors are just going to gaslight you into believing I'm not real. That's awful. That's me. I'm awful. Go to bed. My skin is so itchy. I know, right? It's getting weird.
I wanted to watch the
story.
deeper
My
facts.
husband came up with and wrote this entire script. I wanted to write something funny about how my hormones are running my life and give kind of the different personalities of the symptoms. And Penn wrote this entire thing in 4 seconds about perimenopause, because we do have another person in our marriage, and that is Perry. Perry is new to our marriage. She shows up at weird times. And my husband has been so patient, but sometimes Perry makes me feel a little bananas in a way that is new and fresh. Right, honey?
Right, honey?
When fresh. Maybe fresh. And we're acting poorly and I'm behaving in a way that he's not used to. I'm just going to say it's not me, it's Perry. So use that too.
Use that too. So I really like this. I don't know if you've ever seen this one. The Holdermans, they have such fun YouTube videos. They do really fun stuff on pickleball if you haven't seen it. But I wanted to give you that because I think you can use Perry as a tool with your significant other or your friends, or it's just Perry. She's back again. So open up the conversation, give them this letter, show them funny videos, direct them to shebang and questions. That's it.